Good afternoon, dear colleagues. So the topic of my presentation today is chronic hypoxia caused by iron deficiency as a reason for women's health issues and ways to address the problem. Let's start with the fact that the red thread of our Congress is specifically and precisely our personalized medicine. This is undoubtedly very important. When we meet with a patient, first of all, we need to anticipate seeing their current condition in great detail, their current point A, the problem they came with, and predict and foresee what will potentially happen to them if we do nothing. It is also important to prevent complications and after healing and restoring our patient to effectively prevent the further development of various issues. And I dream that our personalized medicine will replace standard medicine, and I hope that such a day will come. When we talk about the functions of iron in the body, iron is generally one of the most important micronutrients in our body, and its functions are multifaceted in absolutely all organs and tissues. First and foremost, it is cellular respiration, tissue respiration, participation in hematopoiesis, and the functioning of the entire enzyme system, practically, especially enzyme of antioxidant system enzymes, of respiratory chain and detoxification system enzymes. This is the division of cells synthesizing RNA. Antioxidant protection is the work of signaling pathways, and naturally the functioning of all organs and systems in our body. This is what the scheme of our metabolism looks like, which Leonid Olegovich knows by heart and can show and explain any chemical reaction. Here in the clinic we have this metabolism scheme hanging, and Leonid Olegovich often reminds us every time we discuss a particular topic about the chemical reaction underlying it. And I want to draw your attention to this. Here is our ferritin, our iron reserves in the body. Here is our hemoglobin. Work. That is our, yes, it is respiration, the transfer of oxygen. This is work. All our enzymes, cytochromes, they all contain iron in their molecules. This is a transport system, for example, carrier proteins and enzymes of the antioxidant system. And also, the most important and very crucial process of energy production occurs precisely in the cell. And indeed, this process takes place in the mitochondria, in the biological context. The conversion of glucose into energy, that is, our task is to provide the cell with energy, and then each cell can perform its function. And pay close attention carefully, without access to oxygen in conditions of hypoxia, how much energy is produced. And in the conditions of oxidative phosphorylation, that is the very Krebs cycle, where one molecule of glucose produces 36 molecules of ATP, and the enzymes of the respiratory chain, for example, mitochondria, are all iron-dependent enzymes. And then, when we studied hypoxia at the university, tissue hypoxia, hemic hypoxia, and circulatory hypoxia, we were taught that tissue hypoxia develops as a result of poisoning by various toxins, leading to the blockage of respiratory chain enzymes and resulting in death. So what do we see today? So when, as a result of iron deficiency, there is a decrease in the activity of the enzymes of the same respiratory chain, our patients live in conditions of chronic hypoxia. That is indeed as a result of poisoning. This is acute hypoxia, acute death, while here our patients are slowly dying if we do nothing. Daily iron requirement. This is not new to you, but I would like to remind you that women of childbearing age and pregnant women, which is particularly relevant for you, esteemed gynecologists, have a much greater need for iron. And speaking of epidemiology, as you may know, iron deficiency anemia is ranked among the 38 most common diseases according to WHO data by the World Health Organization. As of 2020, around 2 billion people in the world suffer from iron deficiency anemia, but this is based on reported cases. We do not know how many are unregistered or undetected. And that very hypoxia I mentioned for us has greater significance in clinical practice in the form of hemic hypoxia under conditions such as the development of anemia, latent iron deficiency, and deficiencies of vitamins B9 and B12. There is also tissue hypoxia, where, as a result of the same iron deficiency, the functioning of antioxidant system enzymes, detoxification systems, and the enzymes of the respiratory chain in the mitochondria is reduced. And here is our scheme of steroidogenesis, which is particularly relevant for you. That is, all our steroid hormones, both adrenal hormones and sex hormones, are all formed from cholesterol. and the enzymes that catalyze the conversion of hormones into one another, such as here are the enzymes of the cytochrome family, and here is the aromatase, without which we will not have sufficient amounts of estrogens, and consequently we will not have a quality endometrium or a regular menstrual cycle. All these enzymes are iron dependent. This shows the frequency of anemia depending on age. And note that in our largest at-risk groups, these are women, children, and women of childbearing age. However, as we age, the picture changes. And already in old age and elderly age, men are perhaps leading. What do you think this is related to? Yes, that is the loss of iron. But still, look, iron deficiency in women is also progressing. But why have men suddenly overtaken?
Yes, that's right.
That is, we have an age-related decline in testosterone. Testosterone is a powerful stimulator of erythropoiesis. After the age of 60, we experience age-related somatopause, when our levels of growth hormone decrease. Against this background, erythropoiesis and overall hematopoiesis in men suffer more. Because they naturally have higher levels of testosterone, these levels decrease, and as a result, anemia occurs even more frequently than in women. Iron deficiency increases the risk of chronic pathology. Note the figures. Hypothyroidism increases by 2 times against the background of iron deficiency, chronic kidney disease by 5 times, oncology by 2.5 times, and chronic heart failure by more than 2 times. This means that anemia significantly exacerbates the course of all chronic diseases and contributes to the development of complications. What are the stages of iron deficiency? Well, as a rule, very often and according to standard protocols, doctors, primarily hematologists, start to take action when there is a decrease in hemoglobin. But when there is a decrease in hemoglobin, manifest iron deficiency, we are already too late. We have already fallen behind by many years because the iron reserves have already been depleted. In the cells richest in mitochondria, when that very energy deficiency occurred, such as when there was already a decrease in iron levels in the plasma, and consequently, for instance, when we have chronic energy deficiency in the cell, indeed, especially when all our iron reserves in the body are depleted, it contributes to the development of irreversible sclerotic processes and worsens microcirculation in all organs and tissues. Therefore, when we see low hemoglobin, it is a tragedy. There are already irreversible sclerotic processes in the body. Therefore, our task is not to wait for hemoglobin levels to start decreasing, but to timely identify iron deficiency using earlier indicators such as ferritin and pregnenolone in the steroid profile, and to make corrections accordingly. A low ferritin level is undoubtedly a predictor of mortality, regardless of hemoglobin levels. A study was conducted on 5,000 patients, aged between 35 and 74 years. And note that with functional iron deficiency, the risk of mortality increased by 30%, while with absolute iron deficiency, it increased by 90%. And the consequences of iron deficiency, since the manifestation of iron deficiency occurs in all organs and tissues, there are accordingly an enormous number of iron deficiency masks. These patients are treated by neurologists for chronic pain, by psychotherapists for depression, and by gastroenterologists because, against the background of iron deficiency, the epithelium of the gastrointestinal tract is one of the fastest renewing tissues. It should completely renew itself every 3 to 5 days. In conditions of chronic hypoxia and energy deficiency, regeneration processes are reduced. And these are the very atrophic gastritis cases that are now even found in young people. At the age of 30, we typically observe atrophic gastritis as a consequence of impaired food absorption and an even worsening deficiency and hypoxia, including iron deficiency. Therefore, indeed, this is an overall decrease in all types of immunity. What is very important, especially for you, esteemed gynecologists, is the reduction of adrenal and gonadal steroidogenesis. Reduced thyroid function leads to insulin resistance, oxidative stress, and the development of obesity and diabetes. And what is also very important for you is the complication of pregnancy. Because if a woman's blood pressure starts to rise in the 2nd trimester, it is certain that you missed the iron deficiency in the 1st trimester. And already in the 2nd trimester, when the fetus is growing. There is active growth of organs, and their pressure begins to increase. And what do gynecologists and obstetricians usually do exactly in women's clinics? These women are prescribed Dopiguide, and they are taken on Dopiguide because it is very important to prevent severe gestoses in the late stages. But it is very sad that the deficiency of iron is not monitored often enough and is not replenished in a timely manner.
I had a significant amount of experience.
I worked for 2 years at the reproductive center. As a cardiologist, I always ran away from pregnant women because I was afraid of them. It happened that while working at the reproductive center, I had to deal with pregnant women, as all of them had complex cases, meaning they initially faced infertility. Generally, their pregnancies were complicated, and I had to monitor these women during pregnancy as a cardiologist, as a therapist, and as a gastroenterologist. And I had already studied at the Department of Endocrinology with a course on cholesterol medicine under Slana urine, where I learned to timely identify and correct iron deficiency. We administered iron to our pregnant patients. We gave it during the second trimester without any issues, and they transitioned into the third trimester with good blood pressure. Later, the obstetricians thanked us because of the good labor activity, with no tears during childbirth, and they had a quick recovery. In other words, the problem was identified and treated in a timely manner, which prevented a lot of complications during childbirth and facilitated the postpartum recovery period. And our priority tasks? Our priority tasks are early diagnosis, timely quality treatment, and prevention to avoid the development of iron deficiency. All patients, upon arriving at our clinic before meeting the doctor, fill out a questionnaire on iron deficiency. You can follow the link, download it easily on the doctor platform, simply fill it out for those who haven't done so yet, and you can give it to your patients. It can be printed and distributed so that you can see the numbers. If the score in the questionnaire is 10 or more, this patient of yours most likely has an iron deficiency. And this will assist and guide you in a comprehensive manner in broadening and expanding the necessary level of examination that you should conduct. Laboratory diagnostics of iron deficiency, in addition to a complete blood count and reticulocyte count, which is very important, is also a powerful marker of hypoxia. What does it mean when we see an increased number of reticulocytes in the peripheral blood? This indicates that compensatorily, the patient is experiencing stimulation of the bone marrow because under conditions of hypoxia, a greater amount of oxygen transport is required than what is currently available. Accordingly, reticulocytes are released into the peripheral blood in greater numbers earlier than usual to meet the needs of the body. We also definitely check ferritin, transferrin, iron binding capacity, and the percentage saturation of transferrin with iron. Hepcidin serves as a marker for anemia and chronic diseases. This is an early marker of iron deficiency, the lack of iron for quality steroidogenesis, which is pregnenolone in saliva. Pregnenolone is a prohormone for us. It is inactive and is formed from cholesterol. From pregnenolone, all adrenal hormones and all sex hormones are produced. So, what do we see? The very scheme that you were shown regarding steroidogenesis when in conditions of iron deficiency, the activity of the enzyme system, the cytochrome enzymes, and the same aromatase decreases. And accordingly, this process leads to a situation where we accumulate a precursor, pregnenolone accumulates in the body, while adrenal hormones decrease significantly, just as our sex hormones may also decrease over time during prolonged iron deficiency and hypoxia. And accordingly, very often we have already eliminated the iron deficiency in our patients, meaning they have good ferritin levels and peripheral blood results. However, if we see elevated pregnenolone levels in the saliva analysis, this serves as a trigger for us, indicating that it is still too early to stop and that we have not yet fully addressed the hypoxia in this patient. The criteria for diagnosing iron deficiency anemia adopted in Russia state that, according to Russian recommendations, anemia is considered to be a decrease in hemoglobin below 130 for men and below 120 for women.
And there is less ferritin.
Approximately 30 milligrams per deciliter. However, in 2020, the American Gastroenterological Association released new guidelines dedicated to the diagnosis and treatment of iron deficiency anemia. And note that the reference value has been revised. Specifically, the norm for ferritin has shifted from 15 to 45. That is, a ferritin level of 45 and below indicates anemia. We have extensive clinical experience in observing patients with observations conducted over a long period. According to experience, the reference values for the lower reference of ferritin are weight plus age. Weight plus age are the minimum values that a patient should maintain, but often this is not enough. It is important. Everything depends on the level of the patient's activity and whether there are any chronic diseases present, such as diabetes or hypertension, for example. For example, a pregnant woman, of course, her weight plus age will generally be insufficient. And accordingly, we rely on clinical signs. For example, a patient has a ferritin level of 100, let's say, at the age of 30. A woman weighing 70 kilograms with a ferritin level of 100, for instance. It seems fine, but at the same time you notice that she has tachycardia. At rest, her pulse is 90. She complains she sleeps poorly, it's difficult to wake up in the morning, and she lacks energy for life. She has wanted to go to the gym for 6 months, but for some reason keeps postponing it.
So what does this mean?
For her, these values of ferritin 100 are insufficient because you clinically observe objective tachycardia as a manifestation of hypoxia at rest. And accordingly, for this patient, you may need to carefully monitor and, in particular, try to consistently and effectively raise the levels to higher values. Who should treat iron deficiency? According to the order of the Ministry of Health of the Russian Federation, number 169, any doctor can treat iron deficiency. A doctor of any specialty. Indications for therapy with iron preparations. Often latent and manifest iron deficiency in the absence of contraindications. It is recommended to use parenteral iron preparations in the absence of contraindications. In cases of latent iron deficiency, including during pregnancy, it is necessary to correct it with oral forms. Note that compensating for iron deficiency leads to improved function of the gonads, such as, look, in September 2022, this woman had a ferritin level of 37. There is a testosterone deficiency. The progesterone levels are also not very high, but look at how high the pregnenolone is. In February, with ferritin levels at 154, note how steroidogenesis improved without the use of hormone replacement therapy. Limitations on the prescription of iron preparations. This is all clear in hemolytic anemia, in liver damage, in transferrin deficiency. Now we are faced with the problem that we often see both iron deficiency and low transferrin levels. In these cases, when transferrin levels are below 2 grams per liter, parenteral administration of iron preparations is undesirable. It is better to limit to oral forms. And today I want to tell you about a medication that has recently become a discovery for me. This is a new innovative form, an iron preparation called Synthesit, which was created in 2019 by Russian scientists led by Vladislav Karabanov.
What did they receive?
They obtained an iron molecule, specifically an atom of iron, with a different isotopic composition than the usual iron in particular. And note that you see we have 4 main isotopes of iron. And in the molecule of the synthesized, there is much more. There is 30% less of synthesized 54. And thus, its properties are in a significant way different compared to other iron preparations, especially when considered in various contexts. I will show you several studies. There was an in vitro study carefully conducted on a group of volunteers. They took blood samples and examined the enzymes involved in the catabolism of nucleotide bases, adenosine, deaminase, and xanthine oxidase. These enzymes increase with age. They processed the blood, added a liquid form of the synthesized to the blood, and observed how the enzymes would change.
Look, oh, what is that over there? Oh, that's it, right? I wonder.
It is important to note that first and foremost in the older age group, the levels of both adenosine deaminase and also xanthine oxidase are significantly higher in both the blood and also in the erythrocyte. After the exposure to the chemical compound known as synthesit, there was a notable and significant decrease observed in both the enzymes present in the blood plasma as well as in the erythrocyte membrane. This study was conducted at Central Clinical Hospital, Administration of the President, on patients with oncological pathology. There are 99 patients. There was a control group of 19 patients, 38 with colorectal cancer and 42 with various lymphoproliferative disorders. During chemotherapy, they were given the drug synthesit, and pay attention to how the blood parameters have changed. Erythrocytes, hemoglobin. Look, there is a considerable increase in all blood parameters, such as also pay attention to how the performance indicators of the antioxidant system's enzymes have slightly changed. The coded bases were significantly, as you can see, reduced against the background of treatment with synthesin, and clinical patients noted a significant decrease in asthenia, a reduction in tachycardia, normalization of blood pressure, and a decrease in nausea. They tolerated chemotherapy much better, and the results observed from the treatment were impressive, despite the medications being administered during chemotherapy. The changes in red blood cell parameters are, of course, simply astounding. The recent investigation of synthetite was conducted here. It is a new study on animals, specifically macaques without iron deficiency. There were also significant changes, an improvement in hematopoiesis, an enhancement of the immune modulating effect, and its safety has also been proven. Here I want to show you the results of a patient. This is my patient who is 41 years old. I was leading her case together with gynecologist. She approached me in February, at the end of February this year. Complaints of general weakness, increased fatigue, prolonged heavy menstruation lasting up to 10 days, irregular menstrual cycle, breast tenderness during the second phase, and long-standing constipation. What do we see in her tests? We see a decrease, quite low ferritin. The patient is already practically in menopause, high levels of FSH and LH, sufficient high SHBG. She has been under the observation of a gynecologist for a long time, but over the past year she has been on progesterone. Additionally, our gynecologist added estrogen for her, and we replenished the iron deficiency. And pay attention, these values are already in August. Look, we have doubled the ferritin levels, and look at how the FSH and LH indicators have changed, as well as how SHBG has changed. The results are simply colossal. And take a look at her ultrasound. That is, she practically had no ovulations here, only a few follicles, adenomyosis of the uterine body. Here is the ultrasound from February, and here is the ultrasound from August. Look, in each ovary, she developed 6 to 7 follicles. Adenomyosis has completely disappeared, and there are still myomatous nodes. But this picture, I believe, deserves attention, and your focus on the fact that the patient was undergoing hormone replacement therapy, but the improvement in iron levels and the elimination of hypoxia have significantly enhanced her steroidogenesis. I remind you of our health quartet. You can take a photo. And I want to tell you that not meeting the standards is inexcusable. What does a person feel when, at 41 years old, they first stood on their hands?
This is me today, right now at the Congress.
This is my first presentation. Thank you for your attention, dear colleagues. If there are any questions, I am ready to answer.
Where exactly are we?
It has variable valency, for example, 3 and 2 valent. It undergoes changes. I can't say the price, take a look.
It will be very difficult to explain that there are prices for 3600 iron, both for non-edematous and edematous preparation.
In this case, if you experience an effect for 100 rubles, you should continue taking them.
Here it is.
Well, I do not simply control the cost. My task is to clearly and effectively communicate to you the effectiveness. I used it myself. I used it for a month, and my ferritin increased by 100 units. It was 220, and it became 330 after a month of taking it. Usually, to increase ferritin by about 100 units, around 2 infusions of iron are needed. To raise the iron levels by 100 units with oral iron supplements, it takes about a year. Therefore, the question is how quickly you want to obtain results for this patient, perhaps. Indeed, it has very good tolerability. It does not cause nausea or constipation. very high bioavailability. Although the medication is not of a high dosage due to its high bioavailability, it is well absorbed and easily tolerated even by patients with intestinal dysbiosis. Right now I have a group of 20 patients participating. I want to see the effectiveness of the producers. They kindly agreed and gave me the medication for testing. My patients are taking it for 2 weeks now. Not a single patient has complained about anything. No dyspeptic symptoms or nausea have been observed so far. It undoubtedly has the highest bioavailability.
Higher bioavailability.
For me, in my personal experience, it functions like an intravenous drip.